Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am glad to be joining you back in the Sunflower House. And today's topic is about colorectal cancer. Welcome to March of 2023. It's the month that we focus on a very common cancer that has really good screening. And not all cancers have screening tests. And so the ones that do, you really want to know about for you and your family and to avail yourself. I certainly have had a lot of personal and clinical experience with colorectal cancer, having had friends, many patients, and family members with colorectal cancer, especially at a young age. My husband, Tom, was not very happy when I got him signed up for his first colonoscopy in his 30s, but his paternal grandmother died very young of colon cancer. And I have had close family members diagnosed at young ages in their 30s, and coworkers, and of course, legions of patients. So it's certainly near and dear to my gut, let's say, the importance of early colorectal cancer screening. And it is the third most leading cause of cancer diagnosed in the United States. And unfortunately, the rate of colorectal cancer has steadily decreased for older adults, but not younger. So that's really concerning because we're trying to, by screening, reduce productive years lost of life. So according to the American Cancer Society, the number of people under age 55 diagnosed with new colorectal cancer has nearly doubled since 1995. Despite this age group shrinking in the overall population by more than 10%. Our birth rates generally are down, and we have less younger people. So it wasn't, it's been a while actually since the American Cancer Society issued new guidelines, including for people just of average risk for colorectal cancer to start at age 45. I was kind of surprised and upset when a friend of mine, who's also a patient, who will of course remain unnamed, was getting her first colonoscopy at 51. And she's like, I'm not really that past due. And I'm like, yes, you are. Well, I don't have anybody in my family that has colorectal cancer. So you're average risk. Average risk people are still supposed to start at age 45. So you might look like you're not even 45, but we've got to look at the birth certificate. And if you are, you've got to be screened. Now, some of this content that I'm taking is from a column that we have on our speakingofwomenshealth.com site. And it's by a former graduate, a recent new mom, Dr. Taryn Smith. And she is a women's health specialist at Mayo Clinic. She finished her 2-year fellowship with us at in the summer of 2020. And she wrote a column about rethinking colorectal cancer and colon cancer screening and what people need to know. And she mentioned, of course, that March is National Colorectal Cancer Awareness Month. And since it's one of the most common cancers in both women and men, it's time for us to focus on screening and hopefully prevention. So she first starts with people who like to avoid screening altogether. And she wants to set the record straight on a lot of the common myths surrounding colonoscopies. Myth number 1, I only need to be screened if I'm having symptoms. False. We don't want to wait till there's rectal bleeding or other problems before you get screened. The next myth is colonoscopy is my only option for screening. That's false. We do have other screens. I don't think they're as good, but some screening is better than none. The other myth is, women don't get colorectal cancer. That's completely false. Women are very concerned about breast cancer and cervical cancer with pap smear screenings that we've discussed. But you've also got to be concerned about colorectal cancer. The other myth is, well, I don't have a family history of it, and I'm healthy, and I don't have any symptoms, so I don't need to be screened. No, that is false. So if any of these thoughts have gone through your mind, it's time to learn the truth about colorectal screening. So what is colorectal cancer? Well, it refers to cancers that affect the colon and or the rectum. And it's the third most common cancer, but it's the second leading cause of cancer deaths in both men and women in the United States. So approximately 1 in 20 women are at risk of developing colorectal cancer in their lifetime. And thankfully, due to advances in screening, death rates from colorectal cancer continue to decline. But even though they're declining, like I mentioned, a very concerning statistic, which we're not really sure why this is happening, but the incidence in younger people is on the rise. So what are some of the symptoms to be on the lookout for? Well, more than half of people with colorectal cancer had no symptoms at the time of diagnosis. Several symptoms can signal colorectal cancer, and they can include a persistent change in your bowel habits. Narrow pencil-thin stools can mean there's an obstruction in the lower colon. Constipation, diarrhea, something that's not right, cramping. And of course, anytime there's any dark, bloody, melanotic, bloody stool, that needs to be evaluated for a GI bleed, and there needs to be a structural evaluation of the GI tract. Weight loss for no apparent reason. Stomach cancer, colon cancer, pancreatic cancer. These are just some of the things we think about. Any unexplained weakness or fatigue, unexplained low blood count, low iron. My very first podcast of last season was on all about iron. And that's a good one to go back and review if you didn't get a chance to listen to that. So who should be screened for colorectal cancer? Well, first of all, this show is not medical treatment or medical advice. It's just information to help empower you to be strong, be healthy, and be in charge. And part of that mission is to educate you and to let you know what experts in the field are thinking. The American Cancer Society has recommended routine screening starting for the average person at 45. Now, the government, the U.S. Preventive Task Force, recommends starting at age 50. But for quite a long time, we've noted that certain groups have a higher risk, and Black Americans generally were already told to start the screening at age 45. Now, you should, of course, have a discussion with your physician and your values and preferences. It's your body. It matters, of course. Insurance costs obviously come into play. Generally, most insurance plans will cover part or all of the expenses in people over age 50. And that's why sometimes people delay till age 50, but you can check with your insurance company if you're 45 or you're not yet 50 and find out. Certainly, if you have symptoms and it's being ordered as a diagnostic colonoscopy as opposed to a screening colonoscopy, that's one thing to consider and discuss with your physician. And as in everything, an individualized, personalized assessment is very important. So let's talk about the groups and populations that do have a known higher risk. Certainly, smokers and individuals who are overweight and sedentary. And so we've certainly seen the rise in obesity. Dietary factors certainly may play a role. Low vitamin D. And you're also considered to be at increased risk for colon cancer if you have had a personal history of colon cancer or colon polyps. And every day I have this discussion with my patients when they say, "Oh, I had a colonoscopy, it was fine." Did they find anything? Well, yeah, just a couple of benign polyps, but they said no problem. Well, what type of polyps were they? What was the pathology? Oh, I don't know. The doctor just said it was fine. It wasn't cancer. But it's very important to know what the pathology is, because a hyperplastic polyp is certainly benign, and most don't show any kind of association at all with cancer. One study that was done showed if you had hyperplastic polyps, you might be at a higher rate for adenomatous polyps. Adenomatous polyps are the polyps that can progress and turn to cancer. And there's a progression. There can be tubular adenomas. Then the next worst stage is tubulovillous adenomas. And then tubulovillous adenoma with dysplasia. And then tubulovillous adenomas that are invading the colon wall, and then frank colon cancer. There's also serrated colon polyps. Sometimes the doctor will say it's a polyp because it looks like a polyp, but the biopsy is just a lymph node, or it's just benign colon tissue. So anytime you have any tissue taken out of your body, you should have the results. And even if you can see them electronically on your electronic medical record, not all the records talk to each other, and you still kind of want some hard copies to keep of important things like surgeries and tissue taken out of your body. Now, if you've had colorectal polyps, particularly some of the ones that are known to progress to colon cancer, you need colonoscopies more frequently. Inflammatory bowel disease, which is certainly on the increase, Crohn's disease, ulcerative colitis, any chronic inflammation of the colon, particularly ulcerative colitis. Another important risk for colorectal cancer is if you are known personally to have a hereditary genetic mutation that runs in your family. And some of the more common hereditary conditions called Lynch syndrome are associated not only with colorectal cancer, but also endometrial cancer, stomach cancer, ovarian cancer. And women with BRCA1 mutations may be at risk for earlier colorectal cancer, and we tend to definitely recommend discussing screening. Now, we've had some interesting podcasts on genetics and cancer risk, as well as specifically breast cancer and some of the more common BRCA mutations that you may want to listen to. So now let's dive right in, no pun intended, to the screening options for colon cancer. There are stool-based tests that generally don't require any kind of advanced bowel preparation and can be done in the comfort of your home. So for very low risk populations or people who've already had colonoscopies in the past that have been negative, especially as people are getting older or have other competing health concerns, that may be something to think about. There is a fecal immunochemical test, the FIT test, that's a stool-based test. But if it's abnormal, you must have direct visualization of the colon. I saw a patient the other day who had a Cologuard test, which is a DNA multi-targeted test, and it was abnormal. And I said, "Did you have colon cancer screening?" "Oh, yes, I had the Cologuard." "Okay, what was the results?" I looked, they were positive. So if they're positive or abnormal, you must go on and have the colonoscopy. So if you have a Cologuard test, which is this multi-targeted stool DNA test, and it's normal, then you can have that done every 3 years. There's also a fecal occult blood test that does require preparation, no eating, raw or very undercooked red meat or other substances that might falsely make that positive. Most people have discarded doing that test. There's a lot of false positives and a lot of false negatives. Now, in terms of the visualization test, a colonoscopy is when a small lighted scope about the diameter of my little finger is inserted into through the anus into the rectum to the lower sigmoid, and then looking at the whole entire colon. There's the descending colon, the transverse colon, and the ascending colon, which connects to the ileum and the appendiceal area. Now, if you're going to have a colonoscopy, you do have to have a bowel prep. There's a lot of different types of prescription preps. It's called by various names: Go Lightly, Movi Prep. They tend to be the most common. There are other ones that can be done. The Miralax Gatorade Prep is one that's a little shorter prep. You can discuss this with your principal physician or gastroenterologist about your options. The United States Multi-Society Task Force on Colorectal Cancer has ranked screening options based on performance features, cost, and practical considerations. So the visual screening tests include, as we discussed, kind of the gold standard, so to speak, the colonoscopy. If it's normal, the recommendations are every 10 years, but there is research out there that shows that even very experienced colonoscopists, if they do a screen on a patient and that patient has bravely signed up for a research test to have 2 colonoscopies done on the same day by 2 different people where they mark down what they find without taking out the polyps, there can be up to a 10% discrepancy. And so in my practice, I have seen women who are just average risk comply. They got their colonoscopy, years ago. It was at age 50. And then they were told 10 years. And then by age 59 and a half, they presented with rectal bleeding and colon cancer. So to be on the absolute safe side, I many times recommend just 7 years if the first one's normal. And if that one's normal and there's no symptoms, then every 10 years. There is another visual test called CT colonography done every 5 years. And then there's the short scope, flexible scope, which just looks at the lower part of the colon. And that's better than nothing because there's some visualization. But what if you have a cecal polyp all the way on the other side that's missed? I kind of describe it like having a mammogram in a woman with 2 breasts of only one side. Okay, it's still 50% screening, but it's not the whole enchilada. I'm not sure if that's really the best metaphor visually. But it's nice that we've had a lot of advances in technology and that we have several options for colorectal screening. And the nice thing about colonoscopy, assuming you weren't in that study that you got 2 scopes in the study and no one took out the polyps, they just marked to find out the discrepancy. Generally speaking, at that time, the polyps are removed and retrieved at the time of colonoscopy. And it's generally a painless procedure. I've had this done at least 3 times. In fact, the last time I was doing my prep, one of my nurses, who will remain unnamed, was teasing me because I needed to start the prep, that night. And a lot of times my little tip is try to get the 8 o'clock in the morning appointment, because then you'll be kind of first in and then maybe you can recover part of your day. You certainly do need to have a driver. And for one of my colonoscopies, my oldest son, Stetson, who's written several columns for us, so you've heard me talk about him a lot. He's the father of Beatrice and Artemis. And maybe one day when they have their temporaries, they'll be licensed. They'll be driving him back from his colonoscopy. So I had my son, Stetson, who had his temps, drive me back for my scoping. Well, when you're still under the influence of medicine, which is why they won't let you even get a colonoscopy usually if there's not a driver right there. He was driving in traffic and oh my goodness. So preferably it's good to have an experienced driver, not someone with their temporaries driving home. Luckily, everything was smooth and fine. And thank goodness he's a good driver. But that was really quite an experience. But getting back to my other personal story about when I was starting my prep, I worked all day, which is fine. And, it was NPO or just clear liquids, which some people don't like to do, but there are health benefits of fasting and you can drink plenty of fluid. It just needs to be clear. You need to see through it. And then I started my prep and I was on my way to one of my son's baseball games. And I'm like, oh, like they usually just have porta potties. And like when it starts to hit, I'm like, you really have to go. And is some urgency, so it's important to generally be at home. And my nurse was laughing because she said, "Oh, why don't you just get one of the Attain devices?" That was a device that was on the market over the counter to strengthen up pelvic floor and rectal tone to prevent fecal incontinence, because she was joking with me, implying I was going to have fecal incontinence. So you do want to plan ahead and not be doing multiple things at once. Like a lot of times we women frequently multitask and do so many things, but everything was fine. They won the baseball game. The product didn't kick in until I got home. So all was fine. The pelvic stim devices, they are not currently on the market, or at least at the time of this recording, because the company couldn't get the microchips from Taiwan. So certainly there is physical pelvic floor therapy for the pelvic floor and bladder incontinence and fecal incontinence, which of course is no laughing matter. That can really be very devastating. And we will cover urinary incontinence and talk about fecal incontinence on a future podcast. So, colonoscopies are done in individuals who don't have symptoms to screen for polyps or cancer, and certainly people that are at higher risk with Lynch syndrome or genetic mutations or family histories of colorectal cancer, especially earlier colorectal cancer, as well as those that have ulcerative colitis have to be screened for dysplasia. So generally, again, start at age 45, and anyone that has had a family history or siblings or children with colorectal cancer or polyps, especially at a young age, may need to be, of course, started screening sooner, and you need to have those discussions. So what happens before colonoscopy? The bowel has to be perfectly clean, no specks of stool, in the colon. And I tell my patients that before they have the colonoscopy, by the end of the prep, and if you get the morning colonoscopy and you follow the clear liquids the day before, you can start the prep around 6 o'clock at night. And usually, for most people, the bowel's cleared out by 10 o'clock at night, allowing you to sleep, maybe only getting up once at night or maybe only in the morning to have that last bit of what hopefully clear liquid coming out of the bottom, not any flecks of stool. And if the liquid coming out of the bottom is slightly yellow, that's okay. But it's very important to get a clear bowel. And if you have a sluggish bowel or constipation, you might need a 2-day prep of clear liquids. And some patients I tell, which a lot of women in general tend to have maybe more sluggish bowels, especially after childbirth or surgeries or C-sections, that if you already know you kind of have a slow bowel, you might want to start adding a little extra magnesium as a supplement or to your diet a couple of days prior to starting your prep, just to kind of get things like a little bit looser and going. Now, certainly people with renal failure can't take any extra magnesium. And a lot of women don't get quite enough magnesium in their diet. And we have a nice list on speakingofwomenshealth.com of foods that are rich in magnesium, including dark chocolate, by the way. And if you didn't listen to my dark chocolate podcast last year, that's a good one. It goes over mood. Okay, so with your prep, some people might feel a little nauseated when they take it because it can be like a big, big, big jug of fluid to drink. And sometimes sipping it, maybe making it chilled might help. Waiting 30 minutes before drinking other fluids, starting with just a little sip, moving around may certainly help. There are prescription anti-nausea medicines that your healthcare clinician could prescribe if needed.
We'll be back after a quick break. Are you ready to unlock your full potential? I want to introduce you to the Fit, Healthy, and Happy podcast, a powerful resource to transform your life today. With expert interviews, practical tips, and inspiring stories, this podcast is your roadmap to lasting wellness. Here's what a listener has to say.
I used to struggle with my health, but this podcast changed everything. It's like having a personal trainer, nutritionist, and life coach totally for free.
With over 2,000 five-star reviews, we're a podcast you can trust. The Fit, Healthy, and Happy podcast, available now wherever you get your podcasts.
So you might experience a little skin irritation around the anus due to the constant fluids and the wiping. And you might want to apply a little bit of Desitin, which now that I have these grandbabies, I have plenty of Desitin in my house, or even just plain Vaseline. And you can get these cheaply over the counter. You want to maybe wipe the area with some wet wipes that are disposable wipes that you don't put in the toilet but in the trash can, as opposed to just dry toilet paper constantly. That's fine on a daily basis, but when you're going to be going several times, it may be comfortable to do a little sitz bath, putting a little bit of warm water in the bathtub to soak. If you're in Europe, you might have the bidets that are connected to the toilet, but most people don't have that option. If you think there's going to be leaking of fluid, you can place a cotton ball or some padding to absorb leakage. But most people who are neuromuscularly intact, who are able to do Kegel exercises to strengthen the pelvic floor and squeeze the anal muscles closed, usually have, control and continence. So you have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and this March of 2024, which is Colorectal Cancer Awareness Month, we are talking all about colorectal cancer screening, and we're still on the topic of colonoscopy. And an experienced physician uses a scope, which is a long, flexible, half-inch diameter, to view the lining of the colon. My youngest son, Grayson, who I breastfed all of my children for a year, he developed cow's milk allergy that I only discovered when I was changing his diapers after my middle son, Emerson's 4-year-old birthday party, where I made him 4 cakes, ice cream cakes in different shapes. And there was so much ice cream, I thought, I better eat some. So I had kind of a pretty big load of milk protein. And I changed his little diaper and I noticed these little ribbons of blood. So I had, of course, take him into the pediatrician. He needed to get a colonoscopy, which was kind of a scary thought to me for a little 4-month-old baby. And after the procedure, I found out they had used an adult scope. And I'm like, an adult scope on this little baby. So even the adult scopes are pretty small diameter. I still, of course, would have appreciated the pediatric scope, but he was fine. I had to strictly take out all dairy from my diet. So I needed some calcium supplements then. Couldn't even use pats of butter. And the bleeding stopped. After that was treated, he was able to, when he started having table foods after age 1, he was able to have dairy in his diet, which he still does, and he's perfectly fine. And at his last birthday, he had some ice cream. So even sometimes babies and neonates, not necessarily for colon cancer screening, but for other reasons, may need a colonoscopy. So again, the diameter is small for adults. So if don't be a baby, so to speak, about worrying about that. I mean, when you think about the diameter of stool, the muscles are able to open. It's more of a psychological concern, I think, for people. I think you can really be reassured that inserting the scope is not painful. And that's what inhibits a lot of people from getting colorectal cancer screening. And that's a shame. The other thing that's helpful is they start an IV and they can give you medications for both pain and also to relax you. And most colonoscopists are so quick. And in the report, they put how long it takes to do the procedure, about 10 minutes. So it's first inserted through the anus into the rectum, and polyps can be seen and biopsied. Occasionally, the polyp is dropped and it's not totally retrieved, but that's pretty rare. I've seen that occasionally with patients, but most of the time there's tissue, and it may take a week or two to get your results back. And I know that can be an anxious time for people, just like after breast biopsies or skin biopsies or any type of invasive procedure where someone is screening for cancer. But it's best to go about your business, but make sure that you get the follow-up. Might need to schedule a virtual visit or an in-person visit to go over the results if everything is not clear. And also, please get copies of your reports. So many times, this colonoscopy allows for diagnosis and screening and potentially treatment without a major operation, all at one setting. You generally are asked to wear a hospital gown, to remove eyeglasses, not plan to drive or operate machinery until all the pain medicine has worn out. Most people should not plan to go back to work, or should certainly take it easy for several hours afterwards. Anytime I'm in the healthcare setting and I have my ID badge, which allows me to badge in on the computer. I remember after one of my colonoscopies, I'm always trying to get to patient messages and deal with work and get back to patients. And I had badged in, and the nurse came in and said, "Doctor, you're still potentially under the influence. Are you sure you want to be doing emails or answering things?" And I said, "Well, I'm just kind of looking at some benign work." But it was, good. They want to look out for your safety. You generally lay on your left side with your knees drawn up a little bit to your chest. There's a TV screen you can actually watch if you want to, which, of course, being a physician myself, I find fascinating and interesting. And I've certainly done colonoscopies in training and in residency, and it's really very nifty. A small amount of air is inflated to expand the colon so that you can visualize the walls. You might find just a little bit of cramping. Sometimes if there's a lot of scarring or bowel disease or prior abdominal surgeries, it can be more uncomfortable. And some people do need a very experienced colonoscopist. I don't know if my husband's ever going to forgive me, but his first colonoscopy when he was in his 30s, because I was very concerned about his family history, and I didn't want him to die prematurely. And he went there without a driver, and they didn't use any anesthesia because he wanted to get right up and leave. Most people don't do that, and he was not very happy with the procedure, but he had subsequent colonoscopies and subsequent polyps removed, which, like I always remind him, I have saved and prolonged his life more than once. And then the colonoscopy, when it's withdrawn, they get another look. And, you should plan to be at the facility at least a couple hours, but the procedure itself is pretty short, and you're monitored afterwards. You will stay in a recovery room. You might be passing some gas. You might have initially some increase in your blood pressure, but after medicines, it might go down. You're generally told to avoid any alcohol, driving, or operating machinery for, a day afterwards. Afterwards, though, you can, once you're awake and alert, you can resume a normal diet. And you probably want to just take it easy, just like with any kind of invasive, procedures. You don't want to just spring into some intense exercise routine. If polyps were removed, you need to avoid taking aspirin or any kind of blood thinners. If you need blood thinners and you're on medicines like Coumadin or Plavix or Eliquis, there's several different ones. I've just mentioned a few brand names, but there's many. You'll have to be advised when you can resume that. And some people that are very high risk for clotting have to stop the anticoagulation and then be put back on heparin and get bridge therapy. So if you've got a complicated medical history and you require lifelong anticoagulation, it does require some extra planning. So that's a whole lot of information. but it is potentially life-saving information. So be sure to check your medical record when you had your last scoping, when you need your next one, or if you don't want scoping, talk to your physician about the Cologuard screening or other potential screening options. If you've personally had early colorectal cancer or early uterine cancer and you haven't had genetic screening for Lynch syndrome, that's something to talk about. Recently, we keep seeing expansions of indications for genetic testing. In fact, just in this year, the recommendations from APSCO came out to recommend genetic cancer screening for all women under age 65 diagnosed with breast cancer, and even in women over age 65 with certain types of features. So thank you so much for listening to our Speaking of Women's Health podcast, even though it's not necessarily the most favorite topic, talking about colorectal cancer, it's important. And certainly be sure to subscribe to our podcast. You can just hit the follow or subscribe button for free on any of the apps that you use to listen to podcast. Share it with others. You might save a life. You can give us a 5-star rating. You can donate to our nonprofit, speakingofwomenshealth.com. So thanks so much for joining us, and I'll see you back in the Sunflower House next time.